That moment, when your child suddenly struggles for breath, that tightness, it's terrifying for any parent.
Absolutely.
Today, we're doing a deep dive into something really vital, acute asthma in children. Think of this as a focused session, pulling out the essential information you need to grasp this condition clearly and efficiently.
Exactly. We've sifted through the notes to really bring you the core stuff.
Yeah.
Asthma itself, fundamentally, it's chronic. You've got this underlying inflammation and these super sensitive airways that can narrow up.
Yeah.
And you see that typically as wheezing, maybe a persistent dry cough, difficulty breathing, that sort of squeezed feeling in their chest.
Okay, so that's the baseline asthma. And acute asthma is when those sort of everyday symptoms suddenly get much, much worse.
Precisely. It causes real respiratory distress, and often there are specific triggers involved, which we'll definitely get into.
So our goal here today is pretty straightforward. We want you to come away with a solid grip on what acute asthma actually is, what tends to set it off, how you recognize when it's serious, and, the basics of how it's managed.
Sounds good.
So let's start right there. How do we define acute asthma, and what are those common culprits, those triggers?
Okay, so acute asthma is basically that sudden flare-up, a worsening of their usual symptoms, making breathing genuinely difficult. It ties directly back to that chronic inflammation and those hyperreactive airways we mentioned.
Got it.
Now, for the triggers of these acute episodes, well, the notes point to several key things. Respiratory infections are a really common one.
Like a cold.
Exactly. A common cold can easily set it off. Then you've got allergens, things like pollen, dust mites. They love bedding. Or pet dander.
Makes total sense. What else? Anything else that can suddenly bring on an attack?
Oh, yes. Exercise is actually a big trigger for some children. Just running around can cause their airways to narrow. Yeah. And even something simple like breathing in cold air can provoke what's called bronchospasm, that sudden tightening of the airway muscles.
Okay.
Irritants are another major category. Think cigarette smoke, huge one, strong smells like perfumes, cleaning products, even just general air pollution. And interestingly, for some kids, even emotional stress can play a part in triggering a flare-up.
Wow, so quite a range of things.
Yeah.
What about the underlying asthma itself? Why do some kids develop it in the first place? Is there a clear reason?
That's the million-dollar question, isn't it? The development of asthma itself is seen as multifactorial, meaning it's likely a mix of things. Our notes really stress this interplay between a child's genetic predisposition and the environmental factors they encounter.
So nature and nurture, sort of?
Pretty much. We haven't nailed down one single cause, but it seems to be this combination of what they inherit and what they're exposed to that lays the groundwork. And then, when those already sensitive airways meet one of those triggers we just listed, bam, that's when you get that increased inflammation and airway narrowing that causes the acute attack.
Okay, so we have the underlying condition and then these specific triggers for the acute episodes. Are there certain things that make a child more likely, more at risk for these acute attacks?
Yes, definitely. There are known risk factors. A big one is family history. If asthma or other allergic conditions like eczema or hay fever run in the family, the child's risk goes up significantly.
Okay.
Then there's the environment. Exposure to tobacco smoke, even secondhand smoke, is a major risk factor.
Right.
Living in areas with high air pollution, often cities, that's another significant risk. And it's worth mentioning, having frequent respiratory infections early in life has also been linked to a higher chance of developing asthma later on.
That's useful to know. And it seems kind of logical, but what about kids who've already had attacks? Are they more likely to have more?
Absolutely. A history of previous acute asthma episodes is, unfortunately, one of the strongest predictors of future ones. If they've had them before, their risk is definitely higher.
Okay. So we're building a picture of the risks and triggers. But what's actually happening physiologically inside their lungs during an attack?
Right. So let's get into the pathophysiology. During an acute attack, three main things are going on in the airways. First, bronchial hyperresponsiveness.
Meaning?
Their airways are just extra sensitive. They overreact to triggers. Second, inflammation. That chronic inflammation they already have gets way worse.
Okay.
And third, increased mucus production. The airways start churning out lots more thick, sticky mucus.
Oh.
Yeah, so imagine the pipes are already a bit inflamed and sensitive, and now they're swelling up more and getting clogged with mucus.
Okay, so super sensitive, inflamed, and mucusy. How does that translate into the breathing difficulty we see?
Well, all those things together cause the airways to narrow significantly. The inflammation makes the walls swell, The hyperresponsiveness causes the muscles around the airways to clamp down. That's bronchoconstriction.
Right.
And the extra mucus can literally plug up those already narrowed passages. The end result is much less air flowing in and out.
Making it hard to breathe.
Exactly.
Yeah.
Really hard. And that reduced airflow causes the classic symptoms. The wheezing sound as air whistles through tight tubes, the cough as the body tries to clear the mucus, that chest tightness feeling, and, of course, shortness of breath, which often gets worse with activity.
It's so important to recognize those signs. But I guess sometimes other things can look similar, can't they? What else needs to be considered? The differential diagnosis.
That's a really crucial point. When a child has trouble breathing, you absolutely have to think about other possibilities. Our notes mention a few key respiratory ones. Bronchiolitis, a viral infection of the small airways, is very common in infants and toddlers and causes wheezing. Pneumonia, a lung infection, can also present with cough and breathing issues. And you always have to consider foreign body aspiration. Did they inhale something small?
Like a piece of food or a small toy part.
Exactly. That can block an airway. There's also something called vocal cord dysfunction, where the vocal cords close abnormally during breathing, which can sometimes mimic asthma.
Interesting. Are there any other, maybe less common, things that could be confused with an acute asthma attack?
Yes, though less frequent. Cystic fibrosis is a genetic condition affecting mucus, and it can have overlapping respiratory symptoms. Allergic rhinitis, severe hay fever mostly affects the nose, but can sometimes involve cough or breathing issues. And while much rarer in kids, you might keep COPD in the back of your mind, though the cause is different. Even gastroesophageal reflux can sometimes trigger respiratory symptoms in some children.
So definitely things to rule out. Now, how common is this? What's the epidemiology? What do the numbers say for kids?
Yeah, unfortunately, asthma is really prevalent in the UK, particularly among children. The stats suggest about 1 in 11 children in the UK has asthma.
Wow, that's a lot.
It is. And the notes mention it tends to be more common in boys than girls during childhood. And critically, these acute episodes aren't just minor things. They can be severe, often needing urgent medical care, and sometimes, unfortunately, hospital admission.
That really underscores why this is so important. Okay, so when a child is having an acute attack, what are the specific clinical features we should be looking for?
Well, the presentation can vary, but the common signs are those we've touched on. That wheeze, often high-pitched, heard mostly when breathing out. The cough, maybe worse at night or with exercise. Shortness of breath, chest tightness. You might also notice they're breathing faster and increased respiratory rate.
And are there specific red flags, signs that tell you this is a really severe attack?
Absolutely. For children over 2 years old, there are clear indicators for acute severe asthma. Low oxygen saturation, typically below 92%. Being so breathless, they can't talk in full sentences. A fast pulse rate, the exact number depends on age, but over 125 for over 5s. Over 140 for ages 2 to 5. A fast breathing rate, too. Again, age-dependent, over 30 for over 5s, over 40 for 2 to 5s.
What else?
You might see them using extra muscles to breathe, like the ones in their neck. We call those accessory muscles. Interestingly, the loudness of the wheeze isn't always a great guide. In very severe attacks, it can sometimes lessen or even disappear a silent chest, which is very worrying.
A silent chest sounds ominous.
It is, and they might seem agitated or confused, showing altered consciousness. And crucially, if their oxygen saturation is below 92%, plus they have any of those other acute severe features, it's considered life-threatening.
Gosh, that sounds critical. What about the little ones under 2? Are the signs different?
Yes, the assessment is slightly different for under 2s. For moderate asthma, their oxygen might be 92% or above. You'd hear wheezing, see some accessory muscle use, but they're probably still able to feed okay.
And severe.
Severe in under 2s means oxygen sats below 92%. Maybe cyanosis, that bluish tinge around the lips or skin, obvious distress, and crucially, being too breathless to feed properly.
Okay, so feeding ability is a key marker in infants. Generally speaking then, across ages, what are the core clinical features that point towards acute asthma?
Looking broadly, you're looking for signs of respiratory distress. That characteristic wheeze, often described as polyphonic, high-pitched, mainly expiratory. They might complain of chest pain, the cough is usually there, tachycardia, fast heart rate, inability to speak normally due to breathlessness, poor feeding in infants, and you'd consider those risk factors we discussed earlier.
Right.
Also remember, kids with asthma often have recurrent episodes, and the severity can change each time, so ongoing assessment is vital. Maybe a quick example helps. Imagine a 6-year-old, they're wheezing, can only manage short phrases, their oxygen is 91%, and you can clearly see their neck muscles working hard to breathe.
Okay.
Based on those criteria, that would definitely point towards acute severe asthma.
That makes it much clearer. Okay, so a child comes in, you suspect acute asthma. What investigations might be done?
Well, the primary diagnosis is usually clinical based on the history and what you find on examination. That's the main thing.
Right.
Extra tests are more about assessing how bad it is, monitoring the response to treatment, and ruling out those other conditions or potential complications.
So not always needed, but sometimes helpful. What kind of tests are we talking about?
For children over 5, peak expiratory flow rate, or PEFR, is common. Measures how fast they can blow air out.
Okay.
You usually take the best of 3 tries and compare it to their personal best, if known, or predicted values. Oxygen saturation is vital, checking their oxygen levels using a pulse oximeter. If it's low, especially staying below 92% even after some initial treatment, that suggests severity and likely need for admission.
And what about x-rays or blood tests? Are they standard?
Generally, no. Chest x-rays aren't routine for most acute asthma attacks. You'd mainly do one if you suspect something else is going on, like pneumonia or a collapsed lung, pneumothorax, or if there are complications.
Okay.
Arterial blood gases, ABGs, are usually reserved for very severe, life-threatening attacks to check for respiratory failure, assessing oxygen and carbon dioxide levels directly from an artery.
Right, more intensive.
Exactly. And other blood tests, like CRP for inflammation, might be done if you strongly suspect a bacterial infection triggered the attack.
You mentioned severity grading based on NICE guidelines earlier. Could you walk us through that a bit more formally? How do those guidelines categorize the attacks?
Sure. The NICE guidelines give us a framework based on clinical signs and those objective measures like PEFR and oxygen sats. They generally break it down into moderate, acute, severe, and life-threatening.
Okay, let's hear the specifics.
Right, so moderate is generally PEFR 50% or more of their best or predicted, and crucially, no features of acute, severe, or life-threatening asthma.
Makes sense. And acute severe.
Acute severe is PEFR between 33 and 50%, oxygen sats below 92%, and meeting those age-specific criteria for respiratory rate or heart rate. Plus, signs like inability to complete sentences, using accessory muscles, or poor feeding in infants because they're too breathless.
And life-threatening. That sounds like the most critical.
It is. Life-threatening is defined as oxygen sats below 92% plus any one of a list of critical signs. That includes PEFR below 33%, cyanosis, low blood pressure, hypotension, signs of exhaustion, that silent chest we talked about, heart rhythm problems, arrhythmia, very poor breathing effort, confusion, or reduced consciousness.
That's a very clear but sobering list. It really shows how vital accurate assessment is. Okay, so once severity is assessed, how do we manage it? What's the approach?
Management follows a stepwise approach based on that severity. The immediate first step is always short-acting bronchodilators, usually salbutamol.
The reliever inhaler.
Exactly. Delivered via a spacer ideally, or nebulizer if needed. That helps open the airways quickly. If their oxygen sats are below 94%, supplemental oxygen is given, aiming for 94-98%. Systemic corticosteroids, oral or intravenous, are also essential early on to tackle the inflammation. And ensuring adequate hydration is important too. For anything more than mild, or if they're not responding well, hospital admission is usually necessary for closer monitoring and more intensive treatment.
And thinking longer term, how do we try and prevent these acute attacks? What's the focus there?
Long-term management is all about control and prevention. Identifying and avoiding known triggers is key. Regular use of controller medication, typically inhaled corticosteroids, to manage the underlying inflammation is fundamental.
A preventer inhaler.
That's the one. A personalized asthma action plan is absolutely crucial.
What does that involve?
It's worked out with their doctor or nurse, outlining their daily meds, but also specifically what to do if symptoms worsen, when to increase reliever use, when to start steroids, when to seek urgent help. Regular follow-up appointments are vital to check control and adjust treatment. Education for the child and family is key too, and that written action plan empowers them. And communication is important. After a hospital admission, the GP needs to know within 24 hours of discharge. And a GP review should happen within 2 working days. Very severe attacks often need ongoing specialist supervision.
Let's zero in on the acute treatment again. What specific medications are typically prescribed in the moment?
Okay, so in an acute attack, oxygen if sats are below 94% or it's life-threatening. Inhaled short-acting beta-2 agonists like salbutamol are the mainstay via spacer or nebulizer.
Right.
If they're still struggling after initial salbutamol nebs, ipratropium bromide, another bronchodilator, is often added to the nebulizer.
Yeah.
Intravenous magnesium sulfate might be considered if oxygen sacs remain below 92% despite initial treatment. Corticosteroids are crucial. Oral prednisolone is common, or IV hydrocortisone if they can't take oral meds or it's very severe.
You mentioned IV options.
Yes, if there's no response, IV bronchodilators like salbutamol might be needed. And in severe or life-threatening cases unresponsive to other therapies, IV aminophylline is sometimes considered, usually in an intensive care setting. And of course, antibiotics if a bacterial trigger is suspected.
And beyond the drugs, what about the non-prescribing side of management?
Right. So mild attacks might be managed in the community following their action plan, but admission criteria are important. Beating those severe criteria, not responding well to initial treatment, or showing signs of exhaustion warrants hospital admission.
In intensive care.
Yes. If there's no improvement despite hospital treatment or signs of impending respiratory failure emerge, then transfer to PICU, Pediatric Intensive Care Unit, is necessary. For discharge, they need to be stable on their regular inhalers, usually back to needing them only every 4 hours or less, PEFR improving, ideally 75% predicted best, and oxygen sats consistently above 94% in air.
Okay, so it's a whole package. Prevention, effective acute treatment, close follow-up, education, and good communication. Looking forward then, what's the general outlook, the prognosis for kids who have acute asthma?
Generally, with good management, the prognosis is pretty good. Interestingly, the notes suggest that asthma starting very early might actually have a better long-term outcome in some cases. Some children with symptoms before age 2 might become symptom-free by ages 6 to 11.
Oh, that's encouraging.
It can be. However, if asthma starts early in a child who also has other allergies, what we call atopy, the prognosis might be slightly less favorable for outgrowing it.
Are there long-term studies on this, following kids into adulthood?
Yes, some valuable ones. The Belbrin study, for instance, showed that significant childhood wheezing can persist into adulthood. Other research indicates that more severe or frequent symptoms in childhood increase the risk of symptoms continuing later.
But it's not all bad news.
No, not at all. About half of severe childhood cases show significant improvement after around 3 years, and overall severity tends to decrease over time for many. So while it can persist, most children with proper care can lead full, active lives. The key really is good control. Poorly controlled or severe asthma can lead to significant morbidity and impact quality of life.
And finally, what are the potential complications we need to be aware of? The risks associated with acute asthma?
The acute complications can be serious. Respiratory failure is the most critical, where the lungs just can't cope. Pneumothorax, a collapsed lung, can happen. Atelectasis, collapse of smaller lung areas. Hypoxia, low oxygen. Needing intensive care is itself a complication, and there's a potential for long-term impact on lung function if control is poor over time.
Are there other sort of broader complications?
Yes. Things like reduced quality of life due to symptoms or limitations. Sometimes reduced growth can be seen, often linked to poor asthma control itself, or sometimes long-term oral steroid use, though that's less common now with inhaled therapies. Psychological impact of managing a chronic illness. And missed school days, which can affect education.
So preventing complications comes back to good management again.
Absolutely. Proper day-to-day management and prompt, effective treatment of flare-ups are crucial to minimize the risk of all these complications.
Okay, well, this has been an incredibly detailed deep dive. To quickly recap the absolute key takeaways. Acute asthma is that sudden worsening, often with clear triggers like infections or allergens. Recognizing severity using those clinical signs and oxygen levels is vital. Management hinges on rapid bronchodilators and corticosteroids, backed up by a solid long-term control plan.
That sums it up well.
We really hope this session has given you a clearer, more confident understanding of acute asthma in children. If you want to explore more or need revision resources, definitely check out pasthemsra.com and freemsra.com.
Great resources there.
Remember, knowledge is power here. With the right understanding and proper care, asthma in children is very manageable, and kids can absolutely thrive.